June to start, but I just want to introduce June Kong to everybody. She's recently moved from her research from Martino Center to our center here because her passion is autism and pediatrics and clinical trials. So just to give a bit of background, June did her initial medical training in Peking, but they moved to New England and repeated some of her medical training here to get her license here in the state, and is now in internal medicine with assistant professor over at BI. She's been doing research at Martino Center for about a decade now, something like that.
Yeah, 10 years.
10 years. And what really impressed me about June is just her passion for curing autism or helping improve outcomes of autism, and her creativity. She has lots of great ideas. And if you look, she has a number of patents, and which is incredible, the number she has for an MD, which is not that common. So she's very creative and very excited to come up with new strategies to try to improve kids with autism, and is really interested about starting some clinical trials here at BCH, where it's a bit better environment to do pediatric clinical trials in at the Martino Center. So we're really excited to have June here, and so she's going to speak to us now on autism. Thank you.
Yeah, thank you, Ellen, for such a nice introduction. Also introduced me to this wonderful group. So I joined this group about 2 months ago. So I've been mostly online because once this is my clinical day, so I kind of, hard to make it because the patient already booked for months. So I'm so glad to see everybody in person, and also thanks for the opportunity to talk about my, part of my work. Thank you, Carolyn, for all the great, work setting up all this for me. So the topic I'm going to share with everybody is autism biomarker. This is a kind of, bigger part of my research at Martino Center, the value in early diagnosis and subtyping.
And before we start, I just want to ask those online, can you guys hear okay? Do we have the volume all the way up here? I just want to make sure everybody can hear.
I think it's all fine for me.
Perfect. I just want to make sure that you guys hear everything. Okay.
Oh, here. A little bit more about myself. Certainly, I think Ellen already made a very nice introduction. Certainly, I came from Beijing. It was quite some time ago. So I, did some postdoc research training at TOPS and resident training. So later I landed at Beth Israel about 20 years ago. And my research on autism really started in 1999. That's purely for family reason. I raised a son with autism. My son was diagnosed actually Boston Children. And so they initially just as a parent advocate, educator, I learned everything about autism, which is quite new for me at the beginning. He was my first son. And then I built up an autism clinic, a consultation firm, lots of, non-for-profit. Finally, I kind of, when he entered college, I built up this lab at Mass General Martino Center with Dr. Bruce Rosen's help. I've been there for like almost 9 years, almost 10 years. And just recently, I think with Ellen, actually we collaborated before. Certainly I know Ellen, great person and friend. So introduced me to this wonderful group. So hopefully, everything can, with this today's opportunity, get people know me and my research, and also hope to get, learn from everybody to, set up some collaborations. Yeah. Regarding this lab, certainly I established in 2016 when I got funded. I established in Martino Center. Right now, this website is Migrating to Children. And so this lab, the name certainly is more kind of neuronal, connection. As you all know, autism is really, like a puzzle, right? So people don't really understand what, the problem is. So it really means connection. So, so my research kind of been focused on early marker identification. That's just improve the ASD, diagnosis and treatment. For treatment, guidance. The others I run some therapeutic clinical trial, mostly involve, morbidus, oxytocin, and some, vagal nerve stimulation, mind-body stuff. Yeah. So the technology being involved is a lot because my research is exclusively on autism. So I use, microbiota, eye tracking, autonomic, EEG, imaging, pretty much everything about autism. Yeah. So I also run some education program at Martino Center. So I talked to Ellen about, I hope things can kind of move some of these things here. Okay, so today's talk kind of going to focus on, biomarkers, eye tracking, EEG, brain imaging, and microbiota. Before I do that, just like a brief overview, as like review autism a little bit with everybody. As you all know, autism spectrum disorder is a neurodevelopmental disorder, purely behaviorally defined DSM-5, and it's a clinical syndrome with great diversity. People can be totally disabled, nonverbal. People could be like a genius. Yeah. So the two major deficits, deficit in social communication and interaction, and also restrictive repetitive behavior, the two core symptoms. Certainly these days, the prevalence has been dramatically increased over the last 2 decades. And based on the most recent one, which is from 2023, the CDC release in United States, 1 in 36. It's really, really dramatic. And CDC called us the urgent public health concerns. Yeah, but this data actually from 2020, I think as now, there could be more than that. Yeah. So here's just a figure show the prevalence. You can see in 1975, that's like 1 in 5,000. That's why when I was in Mexico, so I rarely heard about this. That's only heard about the terminology, but not really see, anybody. So now, I mean, it's 1 in 36. Certainly, it's 75 for this individual are lifetime, disabled, need a lifetime care. And also ultimately cost nation a huge, huge amount of money, as you can imagine. And the CDC is starting to put this, like a public health alert. And the challenge, yeah.
Prevalence. I'm just wondering, is it because of the diagnosis, like they can be diagnosed?
Yeah, I'm going to talk about that in the next few slides. I'm sorry. Yeah.
Oh, sorry, I could ask you, do you mind if people ask questions during your talk?
Yeah, no,
Okay.
yeah, this is I want to really get know everybody. So I want, please ask questions.
Prevalence, there was one study from, I think, Korea, and they showed like 1 in 38. Autism. It was kind of most like people were talking about the paper that it's overdiagnosis.
Right.
And now it's same in the States, right? It's 1.
These numbers from the CDC United States. Yeah. Globally, I think somewhere from 1% to even higher. South Korea is the highest one. I think 1 in 20 something. So in China, it's 1. I think it's 1%. Because I don't think they have very good statistics. Could be more. Yeah. So certainly they put on a big charge for ASD providers. People are really not prepared for this, big, like dramatic increase. And also there's lots of knowledge. You can see the exploration, the literatures, just amazing. It's a serious shortage for the providers. Boston children, how long people have to wait for initial evaluation? Over a year, could be 2 years. And I remember even back then, my son right now in his 20s. So I still had to talk to somebody like a backdoor service, try to get him in, get evaluated. Long waiting list. Certainly for the family, same as my family. So we experience a lot, very hard to find a good provider, long waiting list, very limited resource, hunting for diagnosis with different opinion, and that causes lots of anxiety and confusions. Certain lack of also school and the hospital that very poorly kind of correlated each other, and fragmented care transition from childhood to adolescent and to adulthood. Yeah, so family experience a high rate of mental and financial burnout. Yeah, that's very true. I run lots of parent group. Very actively in the ASD community is being tremendously affected. So here's a Harvard study from about 10 years ago. It's just been talking about ASD, not only, complete and, unknown pathogenesis, is have a large comorbidities. And certainly, this study involved 14,000 ASD patients under the age of 35. And they concluded this burden comorbidity goes well beyond this routinely managed developmental center, require broad multidisciplinary management that payer and provider can plan for. Yeah. So here's why. That's back to your question. And initially, people just think because right now we have a much higher awareness, and also more people get diagnosed, which lots of people previously is not underdiagnosed. And this is the largest twin study published about 10 years ago. And they also linked lots of 40% beside those diagnosis awareness, still have a half of the patient and no, that's dramatically increased. So the factor that's being kind of associated with lots of environmental factors, computer use, and industry, pollution, and also some parenting illness. Because people tend to get children, older age, the parenting age, diabetes, blood pressure, all this stuff. So also lots of things, the prenatal and the perinatal conditions. Basically, this autism, the pathogenesis started in the prenatal stage. So I'm going to get into that very shortly. So that's why they are real increase. Yeah, in addition to,
Can you explain what does twin study mean? Like, what was the design?
I'm sorry.
Can you explain like the design of the study? I'm not familiar. Like the twin study, what does it mean?
Which one? I'm sorry.
The study that you're presenting.
The percentage, right?
No. I was curious just about the study. How was it designed?
Oh, that I don't quite remember. I think that the references are right there. So
Okay.
yeah, so
I was wondering if it means that they were twin.
twin study. It's the largest twin study. I don't quite remember the detail for the design, so I'm sorry. So I can share that paper with you. Yeah, it's not by us, by the way.
Yeah, it's probably assuming that the twins are genetically identical and they may be in different environments or something like that. That's what I assume.
Actually, the next slide is regarding the genetic, the component. I think certainly for the twin, I think the identical twin, one twin has autism, the other twin like 77% chance of autism. Definitely that's genetically linked. Prenatal twins is 31%, siblings about 8 to 20%. And however, I think the identified gene close to 1,000 that's being all published in New England Journal, but unfortunately, it's a lot of low impact genes. And single gene conditions, lots of syndromic, like Fragile X or Rett syndrome. That's account about 10%, or 10 to 20%, and also some de novo mutations, about 10%, and many genetic overlap with other neuropsychological conditions. And right now considers more epigenetic condition, multi-gene involved. And the gene of microbiota also implicated. So that's why lots of my work, Martino, microbiota research. Yeah. So the pathogenesis is also a myth, still unknown. There are lots of hypotheses being proposed. For instance, the excitation inhibition imbalance, like GABA imbalance, synaptic dysfunction, and then also the disconnectivity. Certain areas are hypoconnected, some areas are hyper, or either connectivity or atypical wiring. Yeah, that's just some kind of hypothesis here. Certainly, our research is more kind of focused around those area. So the pathology certainly back 20 years ago already have a paper, have an autopsy result. They showed that that's microvasculitis, some inflammation mechanism involved, and also hypoperfusion in certain brain area, more like mini stroke. Yeah. So okay, so early diagnosis is really the key of the prognosis. So right now, the autism formal diagnosis by DSM-5 and the ADOS, so that actually is not reliable until 2 years old. That's what most people autism even use this back, maybe they have some early sign, but so they usually the formal diagnosis is age 2. But even though I think that the median age of first diagnosis is much, delayed. For instance, for people who have more severe, autism disorder, is average is 3 years, 10 months, and for high functioning, and not until like 6 years. Yeah. So, yes.
The age of diagnosis, how is different from the age of intervention? I mean, because we can start intervention before we have formal diagnosis.
Yes, yeah.
So is it like big difference here?
Yeah, the intervention, they have an early intervention program for those people who have a suspicion, they start intervention.
Because we used to start intervention even at 1 year and
Yes,
couple of
yeah.
months.
Yeah, yeah,
So
yeah,
way
yeah.
before we have the.
Yeah, way before their formal diagnosis. Yeah. So here's CDC. They have a whole website. They have lots of materials. And so the Massachusetts, this program, I got involved in the Chinese version. They have a local TV show, 8 different language. They kind of show how the normal kids develop, the milestones 1 to 3, and then how the autism patients. So that just increase awareness for the parents to identify the symptoms. So certainly the early sign could be early as in infancy. Certainly, all you can, you just, then you can send kids to early intervention, even you have concern. So certainly, but the pathological change could be early in the, 16 weeks of gestation. That's why, you started the objective biomarkers urgently needed. Because when we talk about the formal diagnosis, it's more kind of psychometric clinical diagnosis. So here I come to the content of the biomarker study. This is the first with the eye tracking. This is the one of our study. We check the eye tracking as a biomarker in autism children. This study involved 37 ASD children and typical development normal controls 37, ages 46 years old. So we sort of designed some kind of a paradigm. They watch the 10-second lady talking without any voice, just silent talking. We identify 6 areas of interest. We see all these area interests that have a reduction of the total fixation time in ASD children. So we use machine learning discrimination analysis. So we actually achieve a pretty good sensitivity, specificity and accuracy is over 80%. So that's one of the study we published in 2018. So this is a different study that published later. So we use a toddler and a preschooler, use the same paradigm. And toddlers 1.5 to 3 and preschoolers 3 to 5 with a little bit more sample. And most of these ASD kids, they have a CAR score 32, 33, which is more, put them in the mild moderate category, not severe kids. Severe kids is very hard to collaborate. So we use a different paradigm. We, like 10 different paradigm to check. That's the result from this study. The upper row is toddler, the lower row is preschooler. You can see we use a 10, the area of interest of 10 single, AOI. The red dashed line, that's represent 90% confidence interval. So then also the accuracy for the toddler seems a little bit more than the preschooler, still kind of over 70, 80% range. Yeah.
How long did that evaluation take? Just out of curiosity, the full battery sounds like was the best, but so how long?
Oh, that's just a less than 2 minutes.
Really?
Yeah, it's
Wow.
very short. You can see every picture they show is about 5 seconds, 10 seconds. The longest one's 25 seconds. Yeah, it's pretty short.
May I ask for the toddler that you said were 1.5 years to 3, was the diagnosis done later? Did you follow them up or was that?
Excellent question. Yeah. That's just like you diagnose them, but it's probably not formal, but they actually use the standard, like they use a CAR score, use the ADOS. Because right now the ADOS, they have a toddler module. And they actually supposedly they can diagnose kids with 1.5 years old, but just not so reliable as the formal ones, 2 years old. Yeah. Excellent question. Yeah. So here we actually developed a new eye tracking matrix, which is published 2024, it's more recent. The good parts I want to share with this actually was done by my son, the autism son. He's a graduate student. He also a research intern at Mass General. That's basically his invention. We used one of the thing we never actually used as a 25-second video. To use this lady actually have this iPad. Just the iPad just show the pictures, running picture, right? Like this go like a running picture. Then you turn on and off. Then you actually see the kids how they kind of fix their attention. Because you normally, when you see that, when the item suddenly turn off, they're going to look at the the woman's face, see what happened. And then the autism is definitely delayed. They still kind of may still focus on the picture or focus on nothing. So then you turn on again, they go back and then kind of go back and forth check. So that you use like a 4 block. And so they develop a new matrix which is called a vacancy. It's just you're not looking or you're delayed looking. And found this matrix much more sensitive than the normally used ones, or the total fixation time and the pupil size. Specificity and sensitivity is much higher. So we also use the same matrix for different, kind of video. This is only 10 seconds. So you look at the woman's, the silent talking woman's face, checking the eye versus their mouth. Because from the previous research, the autism patient more look at people's mouth instead of eye. Even the eye, we think people usually have eye contact, but they don't have good eye contact. So this research is kind of interesting too. So they, after, so the sensitivity expression is almost like 100%, so 80, 100%. Yeah. So p-value is also pretty good. So this paper just published not too long ago. So here's another study. We use both EEG and the eye tracking as multimodal one. And this is we correlate the finding with the ASD score and also the restricted behavior subscore. Because this study we check not checking the social function, we check the restricted behavior. We use a restricted interest paradigm, which is usually the autism patient look at more kind of non-socially related items, for instance, a train, truck, those things, which autism, non-autism, normal people look more parties, people's face, something like that. So you can see the correlation is, not too bad. I think I do have a p-value, both with the ASD score and the restricted behavior subscore. That's the ROC curve. Again, that's over 70% sensitivity and specificity over 90% sensitivity. Yeah, it's use of kind of both EEG and eye tracking. Here's the EEG portion of the same study.
What's the role of EEG in the study? So eye tracking.
What?
What do you extract from EEG?
Oh, EEG. Yeah, EEG. What do you extract?
I mean, what parameters on EEG do you see? Do you look at?
Oh, no, this one's the eye tracking one.
Yeah.
This is the eye tracking, the total fixation time. Okay. The EEG, we did the connectivity. We also did the different like a wavelength power. That's actually 2 different papers we split. Yeah. So here's the EEG portion of the same paper. So here, this one's checking the functional connectivity. So you can see the alpha band under the high restricted behavior stimulus is increased. Higher alpha band connectivity under that means the autism patient usually have obsessive attention to certain things. Yeah, they only look at some non-social items. So here just uses the more machine learning analysis. So the sensitivity, the accuracy a little bit lower, but could be because of methodology and a small sample size. But still okay. I think it's over 60%. So this one just to kind of compare because we use both eye tracking and the EEG. We use their correlation between the alpha band, the connectivity, and the pupil size. Pupil size that's measured from the eye tracking. Also under this restricted, behaviors, restricted stimulus, you can see they all have good, kind of increased pupil size and increased alpha band connectivity. They also both correlate from each other. That's just more the time frequency and power from the same group of same cohort. So you can see here is the theta band is increased. You can see the the picture in the right lower angle there. The ASDs have much higher, so that's also for the restricted behavior. So this is the alpha bands wavelength decreased. Yeah. That's the ROC curve for both EEG on the left side and the eye tracking on the right side. You can see the zeta band, the alpha band on the left side, the ROC, certainly the zeta band seems to have better AUC. And here the total fixation time and pupil size is certainly compared with EEG seems a little bit lower. So that's more we try to use the multimodal logistic regression analysis. Here just the performance multimodal model regression model. Also, you can see the curve here. That's from the same paper. So here's from another paper. So we did purely the QEEG. So we have a 246 ASD patient, average 3 years old, and typically development kids 42, and about also the same age. This is a retrospective study. So you can see all kind of across the board. So the gamma, beta, alpha, and zeta band have some kind of increased connectivity in certain area. More kind of in the gamma band and the beta band. So these certainly, they have all different connections, p-value with different level of the p-value. Yeah. So here's the ROC curve and the PRC curve from the same study. So this is just the performance model, from the LOCV. That's also machine learning analysis. That's a different study. We check the language subtype. So we use the more kind of the auditory process analysis. We check the brainstem response. So here's the first longitudinal developmental study we run that published 2019. So use a small sample size, ASD 15 patient, TD is 20, and it's also preschooler. So here you can see there are two developmental time point at 9 to 10 months apart. Definitely can see the difference, the language impairment for the ASD group compared with TD, and also the picture there to show the time point, 9 months apart. Didn't show the TD, but actually in the same paper, they also correlate with the language score. So this paper just proposed to see the language impairment is a good also early marker for ASD, and also subtyping, certain subtype with more language impairment. They may have different prognosis. Here, back to brain imaging. Yeah.
Actually, the question regarding the retrospective one, I was curious, the one you presented before, the retrospective study you presented before. I was curious, what kind of EEG did you get there? Since it was retrospective, you didn't have a paradigm, right?
The EEG?
Yeah. Was it like sleep? Was it just?
You mean what kind of EEG? Just
during, it was just a regular EEG, routine EEG?
Yeah, regular EEG. Yeah. Recently, we did some sleep EEG. We're just submitted, haven't published yet.
Okay.
I didn't.
No, I was just curious. So it wasn't a paradigm, right? Because it was retrospective.
Yeah,
there wasn't.
Yeah, it was yeah, exactly. Okay. Yeah, it's a QEEG. Yeah.
Okay.
Yeah. Okay, so then the imaging. I know this is all the expertise here, so I really didn't do too much imaging, but I think I want to share this.
Just to point out, Eleanor is an expert in EEG analysis too, as well as Navin. And Cameron. So you've got a lot of people.
I'll learn from you. I'm not an EEG expert, so I'm more clinician. But certainly, we did all this just for with a passion for ASD. Certainly, we check all different perspectives. Later, EEG, we can have a collaboration. I still have some data there, have an analysis. So here's the imaging. I think both resting MR and function MR has been kind of reported as a biomarker for ASD. So this whole thing has started 2017. There was some hallmark paper published. They're not from our group, from somebody else, but this is from our group. This is actually not really early. We did a more kind of data mining research. So the ASD is 40 and TD is 40. Is about 5 to 19 years old. That's really a big age group. So here it's a collaboration with Dr. Jian Kong's lab. So here it's just the social area, the social brain area certainly have reduced, structure connectivity. So you can see that that's the, TD more than ASD, TD more than ASD in this different brain area.
This is interesting. Banu would be interested. She's been doing a lot of tractography in mothers that have been exposed to stressful situations and what areas of the brain are vulnerable to that. And ILF is something that comes up in those studies as well too.
Yeah, I think that lots of things I think can be done here. So because certainly the Martino Center is more for adult. They don't really do children research. That's really I think very excited to collaborate with many of your experts here. So here, just from same study, that still you can see this reduction of this connectivity that correlate with the ASD score. Some of the called the autism, like a symptom score. So which is correlate with ASD severity, which is very nice. This again is the same. So ADRI, that's another kind of psychometric, for ASD diagnosis. You can see here that's the FAF, that's called a low frequency fluctuation. And so that also can see the negative correlate with the ADIR. Yeah. Okay. Similarly, you can see not only ADRI, also the SRS total score, which is a social, response, analysis. Yeah, it's a different kind of psychometric study. We frequently use. I use that a lot for my clinical trial. These are another studies. It's more kind of meta-analysis. So from 9, functional imaging, studies. So you can see here, this ASD patients, 200, and affected family members called the UF is 216, TD is 235. That's from that's a meta-analysis. So you can see here, so ASD, greater than TD greater than ASD, TD greater than UF, UF greater than ASD. UF is kind of in the middle because that's also kind of implicated family, the genetic influence, family environment influence. So there's a few overlaps. So also, those areas reduce the connectivity. That's really the social brain area, which is kind of correlated with a clinical, presentation. So here, this picture is a hyper. It's actually the ASD more than TD, ASD more than UF, UF more than TD. This is more in the restricted behavior and also more kind of amygdala activation. ASD have a hyper, activation amygdala area because of, amygdala area, is more emotional regulation area. People can have anxiety, people can overreacting to certain emotions. That actually make a lot of sense clinically as well. So from this study. So this is not our studies from somebody else. They actually check that's more from the that's a posterior central line area. You can see this group of 33 non-ASD and 34 ASD patient. You can see that's more a group difference. So you can see the control, they have activation there. That's more kind of area control sensory, control, kind of related to social, response. You can see autism totally kind of lack of response there. So it's just see a social world thought. Yeah. So here's another study from our group, and that actually we did also more kind of data mining. So we did a function MRI. That's a function MRI, check the functional connectivity. You can see here, so the left part, that's all kind of TD more than ASD in the, the brain area. So this actually is for the LC and the VTA because all these resource for the main area for the neurotransmitter, and dopamine. Yeah. So for the left part, you can see they all have a reduced connectivity. Certainly that kind of more related, social, maybe more related to, the sensory or either cognitive. So the VT in the bilateral thalamus is increased, So that we actually, in the next slide, we actually think that that's kind of correlate with the repetitive behavior. Repetitive and behavior that's more in the SRS have a called a Manism subscore is highly correlated with the ASD group. And similarly, with that left side figure, you can see the ASD have a higher, VTA activation, in the thalamus area. So here's just a table from that same paper. And you can see the certain area increase, certain area decrease. So the decreased area is more related to social function and sensory or, other, brain functions. Certain the increased part is more related to the repetitive behavior. That's a different paper with the language. That's just we check the speech, like auditory processing study. Check the brain stem response and correlate with the resting MRI. That's certain, with the autism with the language impairment, correlate with the brain area that control the language region. Yeah. That's a similar, just same paper we just talked about. That's just some the hallmark paper from others. They published in a big journal. That's not by us, by somebody else. That's the hallmark paper we're talking about, just brain imaging as a biomarker. They did a infant study. So that certain published in Nature. Hopefully someday we can publish something in Nature. So these people, they have a 106 high risk, because that time is certain the autism not diagnosed. It's just only see the high risk, you just sibling, or somebody have developmental disorder. 42 have low risk, 6 to 12 months. So they found out with certain with machine learning algorithm on the surface area at 6 to 12 months. Certain they actually follow these kids until they're 24 months, until they get a formal diagnosis of autism. It's a longitudinal study. They found to have a very good predictive value in diagnosis at 24 months. 88% sensitivity and 81% positive predictive value. So certainly that's why they publish in Nature. That's really a hallmark, kind of label, open the new avenue for brain imaging value in early diagnosis. Yeah.
One question, like, does the handedness of the kid actually matter in this case? But we don't really know the handedness at this age, right? I don't know. So does that matter? Because like I see some activity there in that region, right? That's the motor region, the what is it called? The yellow region is motor, right?
Yeah.
Yeah.
The area, yeah. Because for autism kids, their service actually increased because that also indicate inflammation. Usually the kids will have a bigger, brain value. And after 25 or some age, they started to kind of decrease. Yeah. So the surface, I think they've been reported a lot, but certainly not from the imaging perspective.
But the handedness of the kids, they don't know whether they're right or left-handed. Does that impact?
That we have something in the paper, but I don't remember the details, so we can definitely read that. Yeah.
1 year, there's no handedness like properly established. I mean, it is 12 months.
Handedness, yeah,
right?
true. Yeah, I think that there are some, kind of study, because we always kind of record that. From our study, we didn't find any significance, but certainly, that could be some other paper that indicate that.
Generally, like if a kid is 6 or 7 months old and he has handedness, it's suspicious that he has some problem on the other side.
Yeah. No, that's a great point. Maybe that's something for future study.
What I'm interested in, how they divided this high and low risk. What are the
Oh, yeah.
factors?
Usually they're just because I done those study before. I usually just only sibling. Like for instance, if I already have an older sibling have autism, these young kids will be under, like a supervision from, their birth. Could be early because we haven't done really prenatal thing. And they are high risk automatically because they are 8 to 20% chance they can get autism.
So like one of the risk factor would be like the only sibling in the family.
In the family, the older sibling, yeah,
Older.
have autism, yes.
That's the question here too, like here, and also some of your eye tracking have really high sensitivity and positive predictive value and all that. And this paper is written in 2017, yet nobody uses anything like this.
Right.
So I'm just curious, like of all the paper, we keep seeing a number of things, like even your eye tracking
Yeah,
has incredible, like the paper your son did,
yeah,
have really good sensitivity,
Right.
specificity, accuracy.
yeah.
But no, why isn't everybody using this? Is there no clinical trials or
No clinical trial. I think
is that something you're thinking of doing? Because
yeah, we can do it. There are too many. Yeah, we can definitely do that because eye tracking, they're it's pretty easy to use. Still not clinically approved by FDA. I think you need a more clinical trial data because the thing we did was more kind of cross-sectional. Yeah, so I think the next step definitely. By the way, that study that my son that actually got industrialized is a patent, and so that patent that the company later may sponsor our trial. Hopefully, yeah. Because they are kind of want to do something with the FDA first,
right,
something like that. And definitely,
Then
that's
they
a
will be.
great point. I think first, I think we develop those simple tools for the early diagnosis. It can be on the iPad. People look at that. You can immediately get some kind of impression, and so for the diagnosis, then they can do further study. And then we also later develop some eye tracking training for the intervention because that will be rightly linked with autism intervention. Because if for instance, if they couldn't focus on that, you can design some kind of paradigm to help them, even with robotic training and some like AI stuff, which is very strong in this group. And I'm learning, so I'm not so good on that. But certainly, I have this idea because I know that's how you sort of crack this to kind of modulate the brain like pathway, the connectivity. That's all more like a computer software. Lots of things not hardware, so that can be reprogrammed. They're very exciting area. We can all kind of work together in the future. So
Sorry, I have a question. So
Yes.
do you know the gender proportion of the Nature paper? So I'm wondering how the big papers contour the, big gender prevalence.
Yeah, that's an excellent question. I don't quite remember because certainly when they follow this patient to 2 years, there are patients diagnosed with autism. There are patients that are high risk and not diagnosed autism. Very likely as low risk, there are none of them diagnosed autism. They have 4 different categories. It's a I think that the majority patient diagnosed autism at 24 months. And but the low risk people, I remember there was one study they don't even have 1 or 2 get diagnosed with autism. And there's still good portion of those high risk, they're not diagnosed with autism. So I think there's there are lots of FNNDSC study. Remember those study we want to collaborate?
Yeah.
Later the funding was withdrawn by somebody, by the company, and we couldn't finish. Remember that we wanted to do the FNNDSC, do the NIR, do the MRI and the EEG. That was back 5 years ago.
Yeah, something like that.
We already wanted to do that study, and I think unfortunately I didn't get through. That's how I know Ellen. And unfortunately that didn't. Otherwise, we will be publish some Nature papers. I think. Yeah, and that's why I see lots of limitation when my research is there. So I want to really come here to learn from everyone. Yeah.
What is the earliest age for eye tracking?
I'm sorry. Yeah.
Earliest age when we can apply eye tracking?
I already say you can do infant. Yeah, the kids if they're as long as they have an eye contact because those 3 months old they have good. The normal kids have good eye contact. The non-normal they actually when we do eye tracking we see 2 months. You can see some difference. Some kids are just like a stare. These kids are probably most likely autism. But certainly you have to wait until 24 months for the standard diagnosis. Yeah. Okay.
And just a note about the eye tracking, actually, there's a publicly available eye tracking and
Yeah.
they've got genomes and everything as part of it, imaging eye tracking, whole, downloadable, but from infants.
Where's that? Is that the UK database?
So this is a function MRI, also this hallmark study, another one, and they also publish in Translational Medicine. So they have 59 infant as high, risk. They also use the sibling as a high risk. Certainly they have, they did function connectivity at 6 months. They also follow these kids until 24 months. So for the, they got 81% sensitivity. Yeah. So there are a bunch of study for the FNIR later. Yeah. So certainly some EEG study as well. They did the longitudinal. We never done this longitudinal study for the infant. We run some cross-sectional infant, but those have not published yet. Here's the fetal MRI. I already talked to several colleagues here, and I hope some study can be done here because
I think they got this data from Children's.
oh really?
That's
Okay.
right, yes, because it was
Yeah.
a group, well, it's published by someone who used to be in our group.
Okay.
And there are some BCH people on there, so I don't know if they got the ICD-9 codes and then
Okay.
looked at the kids and then saw if any of them had fetal MRI, but
Very
I
possible.
suspect
Yeah.
that kind of analysis wouldn't be kind of analysis we do, I think. We do more,
Yeah.
cerebral mantle,
Right.
cortical folding, like something
Yeah.
not regional areas like this, which,
Yes.
they don't, it looks like they're not using even the more modern segmentation tools.
Yeah.
I was gonna say, what's panel D?
That's what it looks like, volumetric segmentations that are not actually that great. And there, I don't see a 3D recon here, so I'm curious. I haven't, well, I don't know, but it doesn't look like it's that good a one. But anyways, I think we could probably do something with the clinical databases because I have a list. Well, we can get access to ICD-9 codes, which give you all the autistic kids. A number of them have volumetric data in the archive. Also, we have another database in the fetal care center where we can connect kid MRN to maternal MRN and fetal MRI.
Yeah.
So that's definitely something that's doable.
Yeah, that'd be great. I think actually, yeah.
They have EEG too.
Yeah, and some of them have EEG too. Yeah, absolutely.
Yeah.
I wonder, I mean, when it's retrospect, I don't know how many get EEG because if
Well,
they
actually, interesting you asked, sorry to interrupt, but I'm just thinking we get a lot referred for imaging because of seizures, 25%, right, have seizure activity. So there's those ones would have EEGs.
but that
because of
would be a specific, right? That would be
Yes,
those
it's a
with,
specific, yes, but I
then
don't know how often they get.
I want to see that retrospective study. That's why I was curious because I wonder retrospectively what kind of data you can get, right?
Yeah.
What kind of
There could be like sleep studies just to rule out Landau Kleffner syndrome,
Yeah.
like no seizure, just to rule out maybe normal ages as well.
and probably they are the one with most comorbidities, I would think,
Yeah,
right? The one
yeah.
that have the EEG because
Yes, yeah. The high risk pregnancy, something like that. Lots of things can check together, like check amyloid fluid, so I want to show next few slides because I know it's really the expertise here because I remember it was several years ago I tried to do this and I couldn't find anybody. At that time, if I know this early, then I probably move here much earlier. So that time I tried to find somebody to do the fetal MRI. I was able to, certainly, Martino Center, they do
Yeah. They don't do it
more
over there.
advanced, so I certainly didn't search that thoroughly. So here just kind of interesting because when the autism right now can consider also autoimmune encephalitis, at least a bigger subtype with that. They actually identify some autoantibodies from both kids and also pregnant women from their amyloid fluid. And I think there was a study, they get the mothers, kind of sample, reserved there until the kids are 3 years old. Then they check, the kids have, the autism mother, and they actually have put their they identify some antibody different from the mother have normal kids. So then this flu they inject to the animal study, they can actually develop autism animal model. So I think that's kind of interesting. They certainly find a lot of different type of autoantibody, not like normally we report it as the autoimmune encephalitis. Usually that happen in a teenager or a young adult. The antibody is totally different. Different kind of antibody. Yeah. So this is the study from my group. So we actually checked the some autism. This is probably 2022. We checked some different kind of autoantibody, including some antibody from the pandas. We found actually a good portion of the ASD, or this is 35 ASD kids, and some of the antibody have a very high titer, like high percentage, some of them have a lower. And so it's very interesting. So the autoimmune component there. This is from somebody else, from JAMA. And so they actually use the PET scan. So you can see the very top row that's normal. So the second one is autism. And then there's different kind of the sectional
What was
picture.
the tracer for this one?
I forgot what's TAPO or something. I forgot the name. I can find this paper. Yeah, it's just indicates the inflammation kind of play a bigger role there. Yeah. That's a microbiome. I don't know how much time I have. I can do quickly.
Yeah, we
Too
have
much?
7 minutes.
7 minutes. Okay, let me draw quickly the little microbiome. Everybody know microbiome, the gut as a second brain that's being attract a lot of attention these days. That's also one of the focus in my lab. And the certain ASD is, currently that's a hallmark paper. So I cited here, cell and microbiome. So you can see they, have lots of hallmark change for diagnosis, and also you kind of give it back to the providers. So you can reverse the symptoms. This is the first paper we did for the microbiome that's published. We did a 20 ASD patient, 19 family member, mostly sibling. And you can see we did both oral, which is a saliva sample, and also the stool sample. We can find lots of, the abundance of certain microbiomes, very different, good RC curve. And we certainly propose that's good for ASD diagnosis and subtyping. That's another paper. We did a microbiome. And we use a double control, which is a family member and also the age match control. You can see the family is really in the middle, so that also kind of interesting. So I think the same thing. Also, that's according to the ADOS score. You can see in the middle. It's very interesting to correlate with the ASD severity. So here, same from the same paper. This is another one because one of another focus I did the oxytocin signaling because I think that's a central mechanism for ASD. You can see here that's from the paper. That's from a different cohort, but also use a healthy control and mother control, which you can see the ASD children really get reduced in the oxytocin level. They also have a sex difference. You can see here, the male seems to have more significance than the woman doesn't. And also the GI, severity is pretty significant. Let me draw really quick, only have 5 minutes. Here's the inflammation marker. We checked the cytokine. That's a different cohort. We did ASD and healthy control. This is a pathogenic organism. We can see it's highly correlated with the cytokine concentration. Here's a study of oxytocin level. So we check, so also have a good correlation with sex difference and oxytocin level correlates microbiome composition. Here's all the autonomic function we did. That's also highly correlated with the microbiota and the ASD severity. So this is from the trial we did, the marker actually also autonomic function have a very good correlation with SRS score and also, the different subscores, different kind of autonomic, function index, the heart rate variability. And here's a trial we did. One of the trial we did is Prader-Willi syndrome. That's one of the syndrome in ASD. We check their, you can see the other side is a clinical marker for the, overall growth and social function, ASQ score. And this side is more for the, metabolic pathway, including the insulin, signaling, because that involves weight and height. That's another study from a different providers that's actually increased the growth. The height was increased after 12 weeks of trial. Here's more function gene regulation. It's more kind of upper regulation, the good gene, down regulation the bad gene. So that's going to be very quick. So here's another study. We did a saliva sample. So you can also see the microbiome changes here. That's more the microbiome network connectivity. So that's also we saw over the treatment course is different. So that's also from the same paper. Here's a combination therapy provided oxytocin. It's also a small trial, 35 people. You can see here the combination really make more difference. It's a synergistic. So also you can see the combination group really makes lots more sense. Okay, I think I'm right on time. So summary, it's really a medical public health, concern here. The early diagnosis is critically important. And also the standard diagnosis is psychometric, subjective, frequently delayed. Early object marker is urgently needed. That's all kind of we're studying mostly focus on. Eye tracking, EEG imaging, microbiota information, autoimmunity are promising biomarker. And a multimodal approach using machine learning, which most of our study uses machine learning. Artificial intelligence show the promise for prediction and classification. So mostly just early diagnosis and also can target in emerging therapies. So here's my acknowledgement. Certainly my lab, it's called the CNAP from Mass General, a bunch of people's listed here, not all. And Martino Center, certainly lots of my colleagues there, so you all know from these people. BIDMC, that's my clinical hospital. And HMS, and also some of the hospital from China. That's all. Thank you so much for listening. Thank you all the excellent questions.